Hello everyone. Welcome to the Allied Talk series. Thank you for being a part of this event featuring Zary Amirhosseini, Disability Program Manager at Massachusetts General Hospital since 2010. Zary will discuss her work on inclusive healthcare access, legal compliance, and innovative equal access strategies, along with her involvement in various disability councils and boards. Let us begin with our talk series.
Hello everyone. Thank you for coming today. Do you want to start off by just introducing yourself first, and then I could talk about Allied? Okay.
What brings you here today, and why are you excited about Allied? I'm assuming you are.
Oh, Zary's. Oh, Zary's here.
Oh, okay, never mind. No, actually, let's make it quick. Let's go around.
Oh, welcome. Thank you so much. Hi, everyone. I'm sorry I'm late. I'm sorry I hate being late. So, but I appreciate your patience.
We have one in conference room camera.
Yes.
And this will be the camera for you.
Okay. Beautiful.
And we have somebody who is actually doing the ASL interpreter.
Okay, great. So, let me just make sure. Can I just manage the slides with this?
If you want, I'll manage it for you.
Wonderful.
You can just tell me.
Which one's easier? Do you want to manage it yourself, or do you want her to manage it?
No, you can manage it if you don't mind.
Sure.
Probably I can just talk.
Yeah.
So, hi everyone. My name is Zary Amirhosseini, and I'm the Disability Program Manager at Mass General Hospital. I've been there for about 13 years, and I'll tell you a little bit about my program as we move forward. But next slide, so I can just share the agenda for today. So today we're going to talk a little bit about disability prevalence in the United States. Talk a little bit about the disability program, its background, and why it was designed at the hospital. And then finally, we're going to talk about disability identity and etiquette, which is one of our main focus in a healthcare setting. Next slide, please. So, first I want to talk about the disability prevalence in the United States. Well, one of the things we know is that there's a high prevalence of disability in the United States. About 1 in 4 adults identify themselves as having a disability. And we also know that there's a high prevalence in this through the disability lens and intersectionality. For example, we know about 40% of bisexual people, adults, and transgender adults identify as having a disability. Also, there is about a 20% rate of disability in Alaska Natives and Native American Indian adults. So there's a high prevalence of disability in certain minority groups. Next slide. Can you go back? Okay. So one of the things that we know is that within the past few decades, healthcare has done a lot of work around making sure that we provide accessible and equitable care for people with disabilities. But since the passage of ADA, which was about over 30 plus years now, our hope was that there would be a more advanced phase of inclusion and normalization or normalcy of disability within healthcare. But one of the things we have realized since then is that there is still a concerning rate of ableism, and I'll talk about that, and significantly significantly underrepresented population. Next slide. So what is the impact of a disability program in healthcare? One of the things we have realized at MGB, I work specifically at MGH, but I also work with colleagues across Mass General Brigham, across the system, which is a over 25,000 patient hospital system. And one of the things that we actually have recognized is that as an educational system, it is our responsibility to encourage normalization of disability within healthcare. And one of the things that we realized is that by being more proactive and creating a more accessible environment for people with disabilities within healthcare, we reduce the cost of care for people with disabilities because when things are not accessible, there's a higher rate of people going to emergency or not following up with their care because they are kind of facing inaccessibility within the healthcare system. So by having a disability program in a hospital setting, we are actually reducing the cost of care. We are also improving efficiency. For example, we are educating our staff and colleagues to know what resources are available for our patients. So we are being really proactive and not, delaying the care for people with disabilities. And finally, again, through the intersectionality lens, we realized that by having a disability program within healthcare, we can reach out to minority communities and for those folks that are underserved and underrepresented within our communities. Next slide. Okay, so how was my program created and why was it created? So my position was created about 13 years ago, and it was in response to 3 patients who filed a complaint against the hospital system as far as the accessibility issues they were facing when they were going for their hospital visits. So they entered what was called at the time a memorandum of understanding, which was one step below suing the hospital. So they agreed with the hospitals to enter this agreement, a 6-year agreement, to look at 4 different areas. One was architectural access, the other was adaptive equipment, the other one was the policies that impacted the care for our patients, and finally, how we educated our staff as far as what was available. So along with that, I know there's a lot of information on this slide, but under each one, we kind of looked at certain things. For example, under physical barrier, we looked at all of our entries, all of our doors, and making sure that, for example, for individuals who are blind, we had braille on all of our signages. Under our accessible equipment and medical equipment, we made sure that we had adaptive equipment that made the environment more accessible for people with disabilities. And I can give you a couple of examples of that. For example, when I go to see my doctor for a checkup, you usually have to get on the exam tables. And I don't know if you guys have ever noticed, but the exam tables are pretty high. So one of the things that we decided to do is look into height adjustable exam tables. And these tables basically go down up to about 17 inches off the floor so that it makes it easier for someone in a wheelchair to transfer. For patients, for example, who have autism, one of the things that we realized is that sometimes the first appointment of the day might make it less difficult for that patient. So we always try to look at scheduling or a less stimulus environment. For example, we move them to a quieter space with less lighting or quieter environment. Under our staff training, we actually have a mandatory etiquette training for our new staff, onboarding staff. And we also have developed training for the physicians and nurses at the hospital. And finally, with our policies, we created several policies. One is about service animals at the hospital. The other one is when COVID happened, everybody was wearing a mask. So one of the things we realized is that with our deaf patients, because everybody was wearing a mask, they couldn't read lips. So one of the things we did is we purchased what they call clear window masks so that they could actually see the provider's lips or people that they work with. Um, so those are some of the things that we've done through our program. Next slide, please. And so this is just kind of a glance about my program and all the things that basically I work with. And one of the things is around consultation. I work with a lot of different hospitals outside of our system in educating them and telling them what the process is for creating a disability program within a hospital system. The other one is reporting. I actually work with our patient and family advisory group and report to them on what things we're doing at the hospital in order to make sure that the environment is more accessible to individuals with disabilities. Next slide, please. So I'm going to let the presenter for this slide talk to you in December. Her name is Karen Turner. But in 2016, Karen joined my program. She was under the Office of Patient Advocacy, and her position was funded by philanthropy. But once the philanthropy stopped, the hospital decided to keep her, and she was then transferred on the disability program. And she has served over 500 patients with autism and cognitive disabilities. So she will really kind of talk to you about the program that she developed at Mass General Hospital. Next slide, please. So one of the things that we are hoping to do is to develop a center that can be a resource for all other hospitals in the country. And one of the things that we are considering is creating 5-pillar program. And the programs would involve patient access, education and mentorship for people who are interested in entering healthcare system and working with people with disabilities, research and innovation, employee support, and finally, continuation of working on policies that impact people with disabilities within healthcare. Next slide, please. So on this slide, I have 4 pictures of our staff and patients who are involved in different activities. The first picture is one of our patients, and she's just basically outside of my office, and she's blind, and she's basically highlighting the braille on our entry doors at our office. The second picture is our sign language staff interpreter, Susan, and she basically is our ASL coordinator at our hospital, and she works with patients who are deaf and also arranges for card services for patients who are late deafened. The bottom corner picture of the lady in a wheelchair is one of our patients again, who is getting assistance with completing forms by a staff person. And then finally, the last picture is Karen and a patient who's autistic. And basically, Karen does a lot of just working on individual care plans with people, again, who have cognitive or autism. Next slide, please. One of the things that we do a lot of and this highlighted on this slide is raise disability awareness at the hospital. Last year, we did this poster campaign called This Is Me, and we highlighted different individuals from different backgrounds, whether they were families of individuals with disabilities, advocates in the community. We had a lawyer and a physician with a disability, and the poster campaign was called This Is Me, and each person was basically highlighted and had a narration of what they perceived as being important, as being part of the community. So we do a lot of disability awareness activities. Actually, October is our busiest month because we do a lot of presentations and have information tables for our staff to learn about the resources. And actually this year, we're doing something really exciting, which is we've developed a what is called an affinity group for our employees with disabilities. And the kickoff is actually next Tuesday. So and I'm co-chairing it.
Is it just for your staff? Sorry to interrupt you, but is it just for your staff?
The affinity group,
Yeah.
the affinity group is basically at each organization, whether it's Northeastern, Mass General, each organization has what is called an affinity group. And it's usually designed for employees that want to come together for support. For example, we have women's affinity group, Black affinity group, Hispanic affinity group. So this is actually our first ever disability employee affinity group. But the beauty of this group is that, yes, it's designed for employees, but not just employees with disabilities, but colleagues who might be interested in working with colleagues with disabilities or parents of individuals or family members of individuals with disabilities who work at Mass General Brigham. So that's actually very exciting. And I'm co-chairing it, so I'm very nervous and excited at the same time. Next slide, please. So along with just raising awareness, we also have, like I mentioned earlier, created policies that impact our community at Mass General Brigham. For example, like I said, the mask policy during COVID, one of the things that happened is on our inpatient side, they wouldn't allow any visitors to stay with the patient. But a lot of our patients, especially those individuals who cannot communicate on their own, we need someone with them at all times. So one of the things we did is we wrote up a policy called support person visitor policy, which actually allowed them, an individual, to stay with the patient who had a disability. So we work constantly on, looking at other policies across the system to see how we can embed disability issues within those policies as well. And the other things that we've also done is we've created a website, both on the public side for patients and on the internal side for our staff to know about the resources that are available for people that they work with. It's kind of like a one-stop shop. So next slide, please. We've also created a toolkit for employees and employers with disabilities. And the toolkit basically is a manual of how to create an accessible and welcoming environment for our employees with disabilities. Next slide. So one is for the manager, the other is for the employees. And so that's basically one of the things that we've created across MGH. We also have other programs. One of them is called the Employee Assistance Program, and they basically do a variety of things. But one of the things that they're focused on the past few years is providing support for not only employees with disabilities, but caregiver of those individuals with disabilities. We also wrote up an article on how to normalize disability within work environment. Go ahead.
We should promote this.
Say that again. I'm sorry.
We should totally promote this. Yeah,
Oh,
exciting.
yeah, of course.
Yes.
I would love
I'm
that.
very excited that you're here.
Oh, I'm excited to be here. This is a website. This slide is actually our website, and I actually designed this website.
Oh.
It's called MARS, and it basically stands for Mass General Accessibility Resource Site. And when we launched it, I played a lot with that word. I said, I wrote articles that, have you ever traveled to Mars before?
Have you visited Mars?
Yes, exactly. We had one of the highest rate of visited websites. So I couldn't lose with that acronym. But basically, this is myself, Susan, who's our staff interpreter, and Karen Turner. So this is our team of providers at Mass General. And so, as you see, there's a list of resources that we include. For example, specific services as they relate to individuals who are blind or low vision, people who are deaf or hard of hearing, people who with cognitive and autism, and people with physical and neurological disorders. We don't have a specific section on mental health, but we are working on that now. And one of the things that we're actually excited about, and I'll talk a little bit more about that, is what we call EPIC, disability flag. So EPIC, at each hospital, there is a health record system where they kind of, it's like a bank of information about you, the patient, whether it's your, what they call problem list or your health issues, what your demographic information is, your insurance information. One of the things that they didn't have, though, was information on disability. And what we've been very successful in creating a disability, what we call a disability identity flag. So if you self-identify, so the beauty of this flag is that a physician is not going to identify you. You have to self-identify. So this is not considered part of a medical clinical identification. It's basically based on how the individual sees themselves and how they want to be identified. Same thing like sexual orientation or say identity. So we have really worked hard on that, and now it's highlighted in the patient's records if they self-identify. The good thing about that flag is that, for example, let's say if you're a patient who's blind, one of the things that you need is alternative format, access to information, whether it's in large print or braille or electronic format. We would know ahead of time if the patient has self-identified.
That's so good.
And requested that as an accommodation.
That's
And
wonderful.
this is something
They're
that,
and creative.
to be honest, now all the hospitals, I'm part of a national organization, and they are really looking at this and highlighting it, trying to embed it within their health record system. So EPIC is a big organization, it's not just for MGH. And we are working with them on making sure that this is part of what they offer as vendor to the hospitals that they work with.
Have any other hospitals started the same thing?
Yes.
Oh, they
Yes.
have? Okay.
Yes.
They got
And because of
inspired.
you guys.
We were
You
first.
started.
We were first. Yeah, we
That's
started
amazing.
in 2010. So, and,
Because I still
yeah.
struggle with that. Like I go to the doctors all the time, and they're
Yes.
like, "Oh, you can do this," and I'm like, "I can't see this form."
Yeah. And you know what? Even, unfortunately, Mona, one of the things that I can say is that even with the flag, that some of our patients are still having the same issues. Because although the flag, thank you so much, although the flag, fixes some of the issues, unless the patient self-identifies, and unless we educate our staff to look for it, they don't see it readily. And so our next step is to make this accessible in all areas of providers' checklist. So not only a certain group can see it, but it would be available. For example, I saw my pulmonologist yesterday, and as he pulled up his information on me, I said, "Oh my God, Dr. Monica, I can see my disability flag. Did you know about this?" He goes, "Oh, I never noticed it." I'll notice it from now on. It's in bright green. So he was laughing, and he basically said,
You're like, "I made this happen."
I did. I actually was showing off, and he loved it. So anyway, next slide, please. I could go on and on about this one, but anyway. So among the other initiatives, we are collecting data on a number of patients and staff that we have with disabilities, which I think is really important in encouraging additional resources and funding for the services that we provide. Web accessibility, that's huge for us. That's one of the things that we are noticing, that a lot of our websites um, are not really accessible, or what they call 2.0, web accessibility guidelines 2.0. I might even be too old for that, I don't know. But anyway, we are looking out for that and that. And the other thing is we are considering as a system to adopt what is called Disability Equality Index. And what that is a group of, is an agency that basically surveys our hospital system and reviews all of our accessibility and accommodation resources, and then rates us as a system. It's not punitive, but it's just good for us as a system to be transparent and know where we're lacking as far as services. Next slide, please. So next I want to talk about disability, etiquette, and identity. And this is one of those things that's very important for us to continue working on. So one of the things that I mentioned earlier is that even with the passage of ADA 30 years ago, that disability has not become normalized within the healthcare system. And unfortunately, there is still a sense of ableism within the healthcare system. Do you all know what ableism is? Okay, so basically it is a sense of discrimination against people with disabilities, just like racism, sexism, or ageism. They basically focus on a group of people that are less than. They consider disabled people as being less than. The difficulty with ableism is that not only they are discriminating against the marginalized group of people with disabilities, but they also view people with disabilities in a medical context rather than a social context. And by that I mean that in a medical context, you look at people with disabilities as people who need to be fixed or treated, or people that don't have a condition that's part of who they are, but something that should be hidden or contained. And that's something we're just trying to really make people aware of as they're on, whether it's conscious or unconscious bias to work on. So next slide, please. One of the ways we do that is we focus on language and terminology. And some of the examples that I've used here, I'm sure you all have heard of. A lot of our doctors, when they write a report, they, for example, just about myself, they say, Zary, a female who's wheelchair bound. And I always tell people, I'm not bound by my chair. My wheelchair gives me freedom to go to work, to come here, to present. So my wheelchair gives me freedom. So I'm not wheelchair bound, but I am a wheelchair user. So make sure you can consider that when referring to a wheelchair user. Or for example, rather than saying people with special needs, because we really don't require a special needs, we require accommodations and services. So, or just say disabled person, rather than the special needs
Like
person.
using generic terms instead
Exactly.
of adding something extra.
Exactly.
You
What were
know,
you gonna say?
my sister always says we all have special needs.
Exactly.
Actually,
Yeah.
like
Yes.
why you like yeah.
You're absolutely right.
Yeah.
Like people's needs will vary from person to person, and that doesn't make it. It's just I need something different than what you need, and etc.
Exactly. Or for example, one of the things that we realized, even with EPIC, as I was mentioning earlier, was our disability identity flag originally was called special needs flag. We changed that right away, And we said, no, it should be disability identity flag as respect to our community. And then we realized within that flag, we were calling everything impairment. Like, for example, we said hearing impairment, visual impairment, physical impairment. But then we said, well, we're not necessarily focusing on the diagnosis or impairment, but we should actually highlight how people identify. For example, physical disability, blind or low vision, deaf or hard of hearing, or deaf blind. There's nothing wrong with just saying it that way. And the more we say it, the more normalized and comfortable it'll become for people to just use it. And the one thing we didn't have in our flag was mental health, and we fought long and hard and we just added it because we feel that a lot of our patients actually do have mental health conditions, and people were afraid that if they include that, then people might feel uncomfortable or feel like they might be stigmatized. But I think that depends on the individual and they're comfortable. If you're not comfortable, you don't have to self-identify. And the other word that we stopped using was handicap. So I'm going to tell you, do you all know where the word handicap comes from? Because I think you should. It's kind of interesting. The word handicap came after, oh my God, it came from England. It came after a war, and I can't remember for the life of me which war. But the veterans, after they came back from military after the war, they were basically putting a cap in front of them because they couldn't find jobs because they were impacted by some sort of injury and they were begging for money. So they put a cap in front of them begging for money, therefore a handicap, a cap that they raise money in. So we like to kind of move away from that terminology and just use disability or basically neutral language, even for like things like parking or bathrooms. Like we used to say handicap stall or handicap parking. We just now say accessible parking or accessible stall. Easy, easy peasy.
It's so interesting. I've always thought handicap, like it offended me a little bit even more than usual because I was like, wait, are you saying that I'm capped? Like like not like the cap, but like my potential is capped. That, you know that I'm my handiness is capped. I don't know.
Oh.
That's how I took it. Like, don't tell me. Yeah.
That's amazing, Laura. I never thought of that.
Because
But now there's another.
I'm like I'm very handy.
I have a question for you. So, what if like the person doesn't want themselves to address them as blind? Like, what if they take offense on that? So, how do we ask them first, or how does that
Yes, yes, and I'll talk a little bit about that later too. But yes, absolutely, we need to just be very cognizant on people's preferences, and that's one of the things that we always talk about to the staff. So, and I included a link here on what we usually share with our communication department as far as for journalism on the terminology, so that when they write things, they can take that into consideration. Next slide. All right, so this slide is basically a bunch of pictures of the This Is Me campaign that we did, and there's a picture of a mom and a son with autism, a family of a patient with cognitive disabilities, a patient who was blind, yeah, that's basically a variety of disabilities. Patient with a Down syndrome who's also a volunteer at the hospital. So yeah, so this is just something I want to highlight. Slide. All right, so we talk about languages and our people's preferences, like you asked. So this slide basically shows a young girl. On one side, she's holding an affinity symbol in her left hand, and that's we consider that person first language, and I'll talk a little bit about each one. On the second side, the little girl is standing in front of the big infinity symbol with her arms stretched out. So there's a difference between the two ways that people in the community, disability community, look at disability. One is called person first language. And a person first language is basically looking at the fact that people are first and their disability, regardless of their disability. So Zary, who's a wheelchair user, right? So I am first Zary, and then my disability, or Zary with muscular dystrophy. My disability is secondary to who I am as a person. So basically, I would say I'm a person with a disability, or I'm a person with a lived experience. And that's a first person language. Then there's identity first language, which is some group of individuals with disabilities feel that their disability is integrated in who they are. They identify their disability as part of who they are. For example, rather than saying Mary is a person with autism, we just say Mary is autistic. That is their identity. Especially in certain groups like the deaf community or autistic community, you're kind of moving towards the identity first language because they just want to be identified as being a community and that their disability is part of who they are. So what we say at the hospital is that neither one is better or worse than the other. It depends on how people use to prefer, how they prefer to be looked at. So we leave it up to the individual and we say, if you're not sure of how to refer to someone, just ask them. And most people usually are comfortable in sharing how they would like to be preferred.
And can I share?
Sure.
I can speak for myself. I also flip around all the time.
I was about to
I
ask
do the
about that,
same.
like,
What are you gonna ask?
oh, I was gonna ask, like, I feel like somebody might switch between how they choose to like identify themselves and just
Yes.
comments about that.
Yeah.
That is absolutely correct. That even if I choose to identify myself as a person first language, which I did when I was younger, I felt like, I just want to be looked at as Zary. I'm not worried about my disability, but as an advocate and as someone who has really identified with my community and with my own disability, and as I've grown, I've realized that there is no shame in just saying, I'm disabled. I'm not a person with a disability. I'm disabled. It's part of who I am. So anyway, that's
Yeah,
my
I do
personal
both.
journey. That's my personal
I definitely
journey.
do both.
Yeah.
But what really to me, I had a really interesting interaction once because I was like, yes, I'm blind. And they were like, don't say that. Like, what do you mean? Like, no. Blind is a bad word. No. Don't say that you're blind. But I am blind. That's when it's like, no, it's not okay for you to tell me how I identify.
Yes.
That's a big no-no. Yeah.
And you know what? I think the more you say that, the more normalized it will become, and the less uncomfortable it is to have that conversation.
It's because people attach, for example, for blindness, right?
Yeah.
They attach so much negativity to it, right? It's like being blind, objectively, it just is, right? But societally, that means somehow your life is over, your future, like this person's coming with all that negative weight attached to the word, and you're like, no, it isn't. Like, I am blind and I am living a great life, like,
Yes.
yeah.
Yeah, I agree.
Can I
Yeah.
add to that? Like, is that an example of like ableism right there? Just like assuming that, oh, you're blind. Oh my God, I can't believe you just said that. Like your life just must be so horrible. And you're like, what?
Yeah.
Or like the blind, like I hope, it gets fixed or something.
Have
you?
Yes.
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 And it's really, I'm like, dude, you just met me.
Yeah, exactly. It's almost like, if you say to someone who's Spanish, oh, Hispanic, oh, Melinda is Hispanic, it's like, all right, so, is that something wrong with being Hispanic? Or, I feel like we should kind of steer away from looking at labels in a negative way. Labels are just part of identity. And I think that we kind of put too much into it, and it doesn't need to be that involved or complicated. So anyway, next slide, please. All right, so don't make any assumptions that all disabilities are always apparent, right? One of the things that you realize is that actually a lot of people have what we call non-apparent or non-visible disabilities. And those could be any disabilities, for example, autism, learning disabilities, um, mental health conditions, chronic conditions. Oh, excuse me. Um, and we've also stopped using the word hidden or invisible. And there is a reason for that. When we say hidden disabilities, it feels that we are actually portraying, or we are saying to individuals, you should hide something about yourself. When we say invisible, we're actually saying that the disability is not visible as part of or identified as part of who they are. So by saying non-apparent or non-visible, we're basically saying that they have it, it's just not visible to the eye. Do you have any questions on this?
I could I feel bad. I feel like I'm talking a lot. So
No,
tell me if
that's
I'm like,
okay. I love it.
So I have endometriosis, like pretty bad.
Yeah.
And it definitely really negatively affects my life in a lot of ways. But like, I have a hard time, like, I don't understand, like, I've kind of like started to think about that as a disability more because like really I can't get out of bed sometimes due to pain. And I also have treatment resistant depression from having a chronic illness. And so for me, like, for example, like a job application, like asks if you have disabilities. And I am like, would be really afraid to disclose that because I would just think like, oh, they're just gonna toss my application to the side, or like even like going to the doctor, like I don't necessarily like to always disclose that I'm a lesbian because I feel like I'm gonna get like mistreated, even though it actually is kind of an important part of like my health. So I don't know if anybody has like experience with that or yeah.
Yeah, I definitely have heard colleagues who call me at a later stage of their employment and say, hey, I never disclosed to my supervisor I have a disability, but now I'm facing issues about the scheduling, like I can't stay up late for a late third shift, but I have a hard time telling my supervisor that I'm taking medication and I can show up this late. So one of the things I always tell people is that you need to feel comfortable at whatever stage in your life to disclose it. And if you're not comfortable with it, then you should talk to someone within whether if it's not your supervisor, there's an office called Occupational Health, the Employee Assistance Program that provide counseling and support. There are people who do mediation between an employer and employee. I'm talking about accommodations. So I think I always tell people at some point you may have to disclose because of what your needs are. It just depends on how comfortable you are. And if you need additional support, there are people who can help with that. Next slide, please.
I want to add something if that's okay.
Mm.
Also, like I just want to say, like you also brought up like so like in your statement like three like
Yeah.
big,
Yes.
intricate, long discussion points. But just to tell you, just even the disclosing of whether or not you have a disability, like I can tell you in the blindness community, it's debated. You know, because some people who are blind, you know, or maybe have low vision, maybe they don't necessarily appear that way. Like it's a whole discussion and debate, and I think like you know anybody who asks might have a very specific piece of advice. So like if you're asking me personally, I'd be like, see if you can. You know, nobody knows better than you from your life experience. Number one. Number two, if you can get to a point in feeling comfortable to disclose, that will help you too.
Yeah.
And it will show what the other person in front of you is like.
Yeah, totally. And I know like
For the good or for the bad.
for like at least one of the examples, like me being gay, I'm like, oh, I'm a bad gay for not telling people that I'm lesbian because I should be proud, you know what I mean? And people shouldn't treat me any differently because of that. But it's still like it's the world that we live in, I guess. Like, and it's unfortunate. But yeah, thank you both for your input.
Yeah, and the more you talk about it, the less uncomfortable it is for people to really deal with it. Maybe it's uncomfortable for you as the first person, but you make it easier for the next person that comes into that office. So, yeah. Okay, so this slide shows a young man who is first seated on a wheelchair, then is standing with a love strand crutches, and then walking. It's the same young man. And the reason why I thought I wanted to show this picture was to really say again around the word assumption, and that we should never assume that disability will always remain the same. Disability, in fact, can fluctuate. Someone who might be using a wheelchair today, you might see them walking around tomorrow. And that might be because of their condition and how they feel that day. Or, for example, we have people who can listen to people who are autistic, can listen to hard rock on their headphones, but then a hospital alarm goes off and they're totally hurting because of the sound. So we cannot assume that just because we see or we have an understanding of a certain disability, that it always remains the same. That in fact, you know, what I like to call it fluidity in disability, and that it changes all the time, depending on the age or the condition. Do you have any questions about this? No? Okay. All right, next slide, please. So, summary. So in summary, one of the things that I mentioned earlier was that disability identity is very personal. It's also intersectional with other groups, and it also depends on environmental factors. And that's something that I really actually didn't touch upon. But the social factors are actually what I call disabling in some ways, rather than the individuals themselves. We recognize that individuals identify with either a specific disability, for example, mobility or blind, or they might identify with a community, for example, deaf community or autistic community, or they might identify as a condition with a condition like mental health condition. We actually have learned long and hard that our issues are best solved when we work with our patients and employees with disabilities because they are the best resource of how we can remedy a barrier. So we always try to teach people to ask, how can I best help you? What's the best way for me to assist you in getting from point A to point B? What are the best ways to accommodate you in your workplace? And I bet you anything, most of us know what has worked for us and how to help you in identifying what our needs are. And finally, Organizations are best when they welcome, respect, and individuals with all sorts of backgrounds. And this includes people with disabilities. Um, yeah, so next slide. And I always like to end with this quote by Helen Keller. The best and most beautiful things in the world cannot be seen or even touched. They must be felt with the heart. So that's it.
Thank you so much, Zary. That's a wonderful quote to end with. And the presentation was so wonderful. I mean, there's so much more to what we see to disability, especially when you brought in like the communication, the fact that how we need to communicate and keep generic terms when we address someone or talk to someone, and also your website. It's really wonderful. Congratulations on that.
Thank you.
And I had one more question, as in, like, when you created this program, was there a lot of experimenting because what fits one doesn't fit all, right? So how did you experiment with many things?
I still experiment with many things.
Okay.
I think one thing is throughout the many years that I've been at the hospital, I'm constantly learning because, again, like I said earlier, you can't assume that what works for one specific individual works for another. So, for example, we have a patient who comes in with a spinal cord injury, and it's at a level where they can transfer easily, they can do most things on their own. And then we have a patient who comes in with a high level spinal cord injury who basically needs to have their wheelchair driven by someone else, or who needs to be able to communicate by a special communication board. So we are constantly challenged by what we are dealing with at that moment. But one of the things that I've really found amazing about working in a hospital setting is that people want to do the right thing, they just don't know how to go about it.
So you're helping them do it.
No, I try.
Yeah.
I try. But I also think that one of the things that has helped me and Karen and people that work with people with disabilities is to really work with what we call champions across the system. So we identify people like, for example, someone in prison security who might also have an autistic child and who's more sensitive in working with people with autism, or someone who might have had their parents who were deaf. And so they might be more sensitive and more knowledgeable about what are some things that might help when you work with people who are deaf. So I think identifying champions when you work with people is really important in getting the message across. Because I'm working in a 25,000 person institution. And so I'm only one individual, but I also know that there's a lot of people across the system who truly care about access, accommodations, and respectful communication and etiquette. And that's what I really rely on. And that's, I think, the most valuable asset in my job.
That's wonderful.
Yeah.
And the amount you have accomplished in so less time. I heard that you started in 2010 as a disability manager.
Yes.
Yeah, and that's wonderful. Thank you so much for this wonderful presentation.
Thank you so much. I appreciate all of your time. I'm so excited. You know, I have to tell you that I started in higher ed. I worked at UMass Boston as the disability manager and then went to Harvard Divinity. So higher ed is near and dear to my heart because I think this is where you guys can kind of think about ideas and explore different things. And so it's great for you guys that you have this group started and to have speakers like myself and Karen, and I'm sure I saw the list of people that you have. I wish I was a student now.
You still can
Come virtually. It's open to everyone.
Yes, I might actually do that.
So our
Oh, we
next,
would love that.
our next event is going to be about speech pathology.
Yeah.
So we have a speech therapist coming in, and she's going to be talking about her experience. It would be wonderful if you could join us virtually.
Oh, I would love to, yeah, definitely, and,
But we'll email you the list, the link. You have the link, I think.
I have the link,
It's the
but
same link the whole semester.
I will definitely try to join, and I really appreciate all of you guys, and if you have any questions, or if you come to Mass General, knock on my door, or send me an email.
Oh, fun.
You know, if you have a complaint, I started on the Office of Patient Advocacy, which is basically an office that hears about people's complaints and requests or feedback. And then in 2020, when COVID happened, they said, oh, well, maybe disability services should really fall under equity, inclusion, and community health rather than patient advocacy, because it kind of it complements the efforts they're doing around United Against Racism and all the diversity work that they're doing across the system.
Yeah.
So that's very important.
So I have a question.
Yes.
If, along those lines, so you talked a lot about how initially it started, it was because of patients, and it was like, really focused on making sure things are accessible to the patients.
Yes.
And then you talked about how like now, there's an employee affinity group, which is awesome. We have one here at Northeastern, that started, but like, how do you feel is the culture right now about being a disabled employee? Like you're actually the doctor or the nurse who has a disability, helping others. What's the culture
Yeah,
on that?
that's a really good question, Mona. I think there's still a lot of work that we need to do in that area, especially when you talk about
Also in higher ed too.
physicians.
Yeah.
Yeah, I mean, it's, I'm sure, like in higher ed with professors and faculty with disabilities as opposed to students, because they're not in the same position of needing accommodations, or maybe they are, but because of the position, they don't feel comfortable sharing. I had a call from a physician with a disability who said, I don't know if I want to bring this up, but I'm having this difficulty. And I thought to myself, and I mean, we had a long conversation, but I was thinking, what a missed opportunity. If this doctor could just share his story, I bet a lot of other doctors would come out of the woodwork and say, hey, I'm having the same issue. So the more we talk about disability, I know I'm sounding like a broken record, but the more we talk about it, the more normalized it will become.
It's just like, it is hard because
Yes.
honestly, like I can speak as faculty, it's just culturally and societally, it's just not expected for the faculty to have the disability. It's always
Yes.
in our idea, in our minds, like, oh, the student will have a disability, but then, hey, don't we want those students to end up becoming, like, if they want to, faculty one day?
Yeah.
It's like the pipeline ends somewhere in the middle.
Yeah, and that's why, Mona, I think one of the things that stood out about you to me and how I found you was because I was looking for individuals that in their own profession are highlighting their disability as part of who they are and making it normal. And engineering to me, it was like one of those things that was outside of my like even thinking. But then when I saw Mona's website, I was like, whoa, individual who's blind and an engineer, what can that be? And then I was pointing with my own biases of how I did internalized ableism. And I was thinking, well, this is wrong. What I'm thinking is wrong. And I should just always challenge myself. So, yeah.
I do have to say though, my website is not as cool as Mars. So like,
Just give me time, I'll find an acronym for your website.
Mercury, I don't know.
Maybe, yeah, you never know. But thank you everyone very much for your
Thank you.
time.
Thank you so much
Thank
for your
you.
time, Zary.
Yeah.
Thank you so much.
This
Yeah,
is like a
thank you.
token of appreciation
Oh,
from us.
you didn't even have to, but I love
We would love to.
Thank you so
So you
much.
can remember us and not forget us.
Remember, the conversation does not end here. Let's carry the knowledge and inspiration we've gained today forward into our lives, our communities, and our work. Together, we can create a world that is more inclusive, more compassionate, and more accepting for everyone, regardless of their abilities. Stay connected by subscribing to our YouTube channel, The Allied Project. Also follow us on our social media, Allied_NEU. We have many more enlightening events and discussions lined up, and we'd love to have you subscribe to our newsletters by contacting us on allied@northeastern.edu. Thank you once again for your participation and support. Until next time, take care, stay inspired, and let's continue working towards a more inclusive world. Goodbye, and see you again.